Yeah, thank you, Dr. Sinimal, for including me in your instruction course. Basically, I prefer to do surgeries without any devices. So this is a small pupil. Exactly what. Hey, where is it? Okay, so this is a small pupil. See, many of these patients I see on table only. You don't know if it is going to dilate with. So what I basically use is Phenokian, no financial interest. So just put it in, and the concentrations of everything in tropic med and everything in that is so low that. So this is another case. Small pupil on table. So I decided to do the same maneuver. Inject Phenokian in. So it is dilating. It is dilating. But is this enough for me to do a surgery with this thing? See, whatever it is, if you do it in a small pupil, stain the anterior capsule with trypanblue, because see, you're going to do the rhexis, and the rhexis has to go under the pupillary margin and go around. So now effectively we will get a rhexis which is larger than the pupil, and I don't know why my first this thing is to go for surgery without any devices. Time factor basically. So see when you're doing a surgery like this, make sure that the phaco tip doesn't go near the pupillary margin. If it goes near the pupillary margin and one catch, then you had it. Throughout the surgery, that iris is going to come to the phaco tip. So if at all you have to go there, just push the pupillary margin to one side and then do it. And even aspiration is difficult. This is another case. It was not a small pupil. So I started the rhexis, and the iris started coming down, and pupil constricted a little bit. So here I decided to put an iris hook. See, it's not the classical way in which it is described. So I initially decided to put the iris hook on either side of the entry, the tunnel. So here the rhexis has been partly done. So you have to be careful. See, this is a very flexible hook, polypropylene hook, and it has got the stopper, silicon stopper there. So you go hook the iris pupillary margin, then hold on and advance the stopper. So the pull should not be in such a way that you have a full dilatation there. So if at all you want a maximum dilatation, it has to be done after everything has been put. See the entry there. So it is posterior limbal. So why I'm doing posterior limbal? Because pain would be there in the topical lens here. You can see the blood there. It's because I gave a posterior subtenance. See, no egos there. See what the result is there. That's what concerns us. So here it's just posterior. It's on the other side of the tunnel. So why do you go posteriorly? See, if it go more anteriorly, you're going to tent up the iris and it's going to come up. Especially if it is subinstitial, you put the hook subinstitial on the sides, and if it tends up, you will hit the iris every time you go in. So that is something that we don't want. See, it is just a posterior limbal here, and when you put in, see, it is here. See, I always like to hold that stopper there because it's such a soft material. When you just hold on to that polypropylene material and push in, it might not easily go in. So see here, here again it is posterior limbal. See, why you should not go very posterior? Because you find it difficult to push it in because conjunctiva comes there. See, the direction of the paracentesis is not parallel, it goes down towards the pupillary margin, again to prevent the tenting. So once this is in place, then you can do the surgery comfortably. So phaco done. See, everything goes off smoothly. See, the biggest problem I had when I started doing this iris hooks was how to take this out. See, some literature says you just pull it out because it's a soft material. But whatever said and done, there's something there and you're going to injure the pupillary margin. So always withdraw the stopper, then push the iris hook inside so that it is away from the pupillary margin. You turn it around. You turn it around that when you pull it, it doesn't hit the pupillary margin. So in the last one, I'll make it much clearer. See, I pulled it up a little bit more. See, hold the stopper, push it in, turn it, then just pull it out. So it makes the surgery so simple. See, result-wise, this is good. The disadvantage for me there is like you have to make 5 entries, put the thing in. It takes much more time than what I do. Like, see, I should not be telling this like as time. For me personally, it matters because of the volume that I do. And the good thing about this iris hooks is that it's not expensive and it is not easy to put this other pupil expanding devices in a shallow anterior chamber. There you can easily put it. So I'll just summarize whatever I've shown here. So the incision, like you have the side port, say MVR blade, or I use a slit knife, which is not to the liking of many people, but I'm used to that. So it has to be small. They say 1 millimeter. You can't actually measure 1 millimeter. It's the smallest this thing. Then, see, I said about the angle. Yeah? See, the angle, if it is like this, it's going to cause tenting. So direct it towards the pupillary margin. Then you'll have the slanting one. Then that tendency for tenting is not that much. Whatever maneuver is there, you should have enough space in the anterior chamber. So use viscoelastic liberally. 4 or 5 hooks. Don't bother about pentagon, this, that, and all. Then again, I mentioned it during my presentation. You just hook it there. Don't pull it to an extent that it's pulled too much. See, the biggest problem, like I'm putting it at 3 o'clock. See, when you put it at 3 o'clock, the whole iris is going to come here. That pupillary margin is also going to come. So it will be very difficult to put the hook there, and also a lot of undue stretching, and you'll have, if you do that, you'll see a lot of sphincter tears at the end. So one by one you keep it there, hook it enough so that when you put the other side port, it doesn't come off. So that is one more. Exactly what I said now. And to remove it, you make sure that it is loose. Hold it at the stopper, push it in, turn it, and then bring it out. Forget about what some big people have said in their articles. Just pull it out because it's soft. No. It causes iris trauma, pupillary sphincter tear. We just pull it out. Thank you.
Thank you, Dr. Sreeni, for that excellent videos and the tips, especially regarding the side port incisions you make for introducing the hook. Should be at the limbus, directed slightly posteriorly. But any chance of iris prolapse through that incision?
You don't have to actually, see, if it is a severe eye phase, whatever small thing you do, it is going to come.
Yes.
So that you can't really anything. It is going to be difficult, but make sure that it is too small. If it is just a pure small pupil, it's not going to come.
Okay.
Absolutely not going to come.
Then another point, can we put all the hooks in the AC and then adjust, hook the iris and adjust
no. See, I don't know. I don't have such steady hands that you put the second side port that the other one doesn't move. No, I put it just in the pupillar man, just hook it a little bit so that it doesn't move when you make the other side port.
Okay.
So that's it.
And any experience with the SICS and iris hook?
It is very difficult actually to do SICS with iris hooks, but for recording purposes, see, SICS I might do small sphincterotomies and do it. Sphincterotomies for a phaco, it might cause trouble because the iris pupillar margin might become floppy at that time and hold it, but SICS, it doesn't matter. And if it is a very stiff pupil, you put iris hooks, you'll have small sphincter tests. SICS, I have done. The important point there is, when you do the nucleus delivery, release it. Okay, otherwise, I mean, it is going to be a mess. So, release it. And that is also tricky. When the nucleus comes, will it bring the hook along with it and touch it? If you are scared of that, remove the proximal ones, totally remove it. See, once it is SICS, the big nucleus comes out, you will have enough space in there for IOL implantation and cortex wash. That won't be much of an issue.
Okay, thank you, Dr. Sreeni. As he is our...
JP sir,
okay.
comments sir, on your experience with iris hooks.
Yeah, with iris hooks, I feel one point is we should never hook to the limbus. We need only about 5.5 in my hands, 5.5 or 6 mm. So what I do is I put 4 side port incisions, as he rightly said, closer posteriorly at the limbus, 4 incisions. Then I introduce, as Cinnamol said, all the 4. Then one by one I insert. First round I slightly increase it to about 4. And then I tighten up a little more and increase it to say 5.5 or 6. That is how I proceed. And always inject. One point is always inject visco under the iris before you hook the pupillary margin, so that you don't poke the anterior capsule. And SICS, I do have black cataract, small people, means I am terrified. I am more comfortable doing phaco rather than SICS. But in that situation, I always use iris hooks. But the sub-incisional hook is always placed right from the sclera, very posteriorly I go in. So it is very deep, very close to the iris root, comes in and takes it out, keeps it back. And that hook I always stretch fully, so that once the nucleus tip comes up, then you can take out the nucleus without damaging the iris. These are the things that I practice. Thank you.
Thank you.
Thank you, Dr.